Okay, let's get going. It's Jim Christenson here. I'd like to welcome you all to October Provincial Emergency Grand Rounds. And we're always very, very happy when our pediatric colleagues are presenting and helping us all learn how to better manage little ones. And my chore today is to just really to welcome you and then hand it over. And I'll do that in just a second. But first of all, I'd like to do something that we will do on a regular basis from now on, and that is to acknowledge where we live, work, and play. And we do that in the traditional and ancestral and unceded territories of Indigenous nations. Where I am right now, these are the Coast Salish peoples, including the Squamish, Musqueam, and Tsleil-Waututh nations. And I'd like us all to just take a moment and to think about what that means. And if you're not in Vancouver, sort of in the university teaching hospitals, et cetera, so you're in different places, to be specific about acknowledging privately the lands that you inhabit and recognize that. So with that, I'm going to hand it over to Melissa Chan now, who's going to be the host for these rounds, and she will introduce the speaker. Melissa is the director of the PEDS-EM Fellowship. And I'm really grateful that that we're able to combine the pediatric and the pediatric academic day with the residents, with all sorts of other participants from across the province. So Melissa, I'll hand it over to you. Thank you very much for organizing this.
Oh, thank you. And it's my pleasure to introduce one of my esteemed colleagues, Dr. Ernst, who is a pediatric emergency medicine physician and the trauma medical director at BC Children's Hospital. So she completed her pediatric and PEM residencies here at UBC and then went to the Hospital for Sick Children in Toronto to complete a trauma fellowship and advanced certification in quality improvement. Dr. Ernst is currently working with the Trauma Services BC on a number of quality initiatives, including chairing the Pediatric Trauma Mortality Review Committee. She's expanding the provincial trauma tiers of service for children and collaborating to improve the BC Patient Transport Network. She is definitely one of the most passionate people about trauma education that I have met, and she's done a lot of work both locally and regionally with courses such as PATS and STRUCK. So I'm really, really excited to have her today to talk. I always learn a ton from Jen, and I'll let her take it away.
Thanks for that, Melissa, and thanks for having me today on this rainy day. Perfect day to talk about the complex task of evaluating the C-spine in the pediatric trauma patient, which causes all of us in a number of different hospitals, pediatric hospitals, adult hospitals, quite a bit of strife. I have nothing to disclose today, and I do want to talk a little bit about our learning objectives for the day. I want to describe the key differences in the anatomy and pathophysiology of cervical spine injuries in children as compared to adults, identify risk factors associated with CSI, and apply a number of different clinical clearance tools to various age groups. Really demonstrate a judicious approach to imaging, which I think is one of the most difficult things that we have to do in this population. Determine which children require spinal motion restriction in the pre-hospital setting, just at the end. So the pediatric cervical spine. So pediatric cervical spine injuries are relatively rare in the pediatric population, and they really only consist of 1 to 2% of all pediatric injuries presenting for treatment. Most trauma centers encounter only a few cases of pediatric cervical spine trauma every year, and as a result, many physicians have limited experience assessing these children, both at tertiary care pediatric hospitals as well as in the community. What's really different about children is that about 80% of spinal injuries involve the C-spine, whereas in adults, it's about 30 to 40%, as many of you guys know. In children less than 8 years, up to 3/4 are axial C-spine injuries, which obviously are associated with a great deal of morbidity and mortality. Younger children tend to die more often from C-spine injuries and have a higher rate of neurologic deficits, head and other major injuries that are associated as well. In terms of mechanism of injury, MVCs and falls still remain the most frequent cause of injury in all age groups. Inflicted injuries, however, in the small children under 2 years are an important cause of spinal cord injury and really require a high index of suspicion so that we don't miss them. As children grow up, sports-related injuries become more and more common, and increasingly recognized mechanisms of injury include axial loading to the head and clotheslining on ATVs. And for any of you who don't know what clotheslining is, because honestly I didn't, it's when drivers of ATVs strike their neck on a quarter wire suspended between two objects. So obviously a very violent mechanism of injury. Some anatomic considerations, and this is where the pediatric spine is really quite different than the adult spine, and subsequently explains why they have very unique injury patterns. Children have a larger head, especially younger children, like toddlers, and their fulcrum on their C-spine is around C2, C3, rather than C4, 5, or 5, 6 in adults. And the fulcrum moves down as the child ages, but this is why our younger age group tend to have higher axial C-spine injuries. When children are anxious, lying flat supine on a stretcher and in C-spine color, they often lose their cervical lordosis, which you can see in this x-ray here, and can lead to misinterpretations of the x-rays as well. Weaker muscles and ligaments combined with the anterior wedging and shallow facets allow for easier anterior-posterior slipping of the vertebrae and subsequent injuries. Patients younger than 8 years of age incur high ligamentous injuries more often than older children and adults. Fractures tend to occur at ossification centers and synchondroses, and these are really weaknesses in the bone that can, first of all, look like fractures and cause it to be very challenging to decide if there's a fracture on x-ray, but also as a point of fragility where the C-spine can fracture. Another consideration in children, which is a bit different than adults, is young children and newly diagnosed children can have a number of predisposing conditions that make them more likely to injure their C-spine and more difficult to assess. This is a list here of various syndromes that are associated with an increased likelihood of both ligamentous and bony injury. On the top, you see the genetic syndromes here, which tend to be associated with spine malformation. The number one that we probably see are the patients with trisomy 21 who have a high rate of atlantoaxial instability. Connective tissue disorders is another issue due to ligamentous laxity that's more than the average child. And disorders of bone metabolism increase the likelihood of pathologic fractures. This slide here comes from a PCARN study several years ago looking at cervical spine injury patterns in children. And what's interesting here is really to look at the difference between the axial and subaxial injuries. In this study, you see a spike in axial injuries, so high C-spine injuries around 3 years of age, and that decreases as the child hits the age of 8. Same thing for subaxial injuries, become more and more common after the age of 8, and really progress towards a more adult mixed pattern that you guys see more in the adult population. Suwara, so non-radiologic positive fractures are also present in all age groups, but a little bit more commonly in the younger age groups. And if you notice here, there's really this age of 8, which is kind of a magical age for C-spine injuries, where you switch from a very, very pediatric pattern towards a more adult pattern at that age. In 2019, Poorman and his team identified over 11,000 fractures among almost 400,000 pediatric trauma discharges from the kids inpatient database in the US. And they demonstrate a similar finding to our previous study here. So in this table or this graph here, you can see fracture rate trends of varying cervical spine levels that are plotted across age groups. C2 by far is the most common fracture, followed by C1 in the infants and children, whereas in adolescents you're starting to see more C7 fractures as well as C6. So again, a more adult type fracture pattern. Beckman in 2020 did a retrospective review of fractures in children less than 16 in their trauma registry at a level 1 trauma hospital over 12 years. Patients really had a high rate of upper cervical spine injury in this cohort. Injury patterns in pediatric patients vary significantly by age, with patients younger than 3 being particularly prone to distraction type injuries. So injuries like atlanto-occipital dissociation and subluxation of the atlantoaxial area and vertebral end plate fractures, all of which can be quite devastating. The table here shows injury types in the lower C-spine, and note that compression fractures are more common in older children and can involve both the transverse processes and spinous processes. Similarly here, we find the same findings as our previous Poorman study, showing that C7 in the subaxial area is really the most commonly fractured. Atlanto-occipital and atlantoaxial dislocation injuries are devastating vertical distraction injuries that occur in very young children. Most commonly, this occurs from a motor vehicle crash and usually results in rapid death. And these are really the devastating injuries that we don't want to see. Dense fractures occur more commonly along the synchondrosis. So this is something that's quite unique to the pediatric population, especially again under this magical age of 8 where the C-spine is strikingly different. The weakest point here is the cartilaginous subdental epiphysis that you can see in this picture. And the mechanism of injury here again is forward-facing child in a high-speed motor vehicle crash with a rapid forward flexion, which is one of the reasons we like to try to keep children in their car seats facing backwards as long as humanly possible. What you can see in these pictures of x-rays and CTs too is on the top on the left, you have a normal synchondrosis, and you can see how easy it would be to potentially mistake this for a fracture, when in fact it's just actually a growth plate. You can see the difference in the lower pictures where you have a subdental fracture and dislocation, where the dens is completely off of the body of C2, and you can actually see some simultaneous T2 changes in the spinal cord on the MRI that's just next to it. In terms of cervical spinal cord injury, upper spinal cord injury is thankfully less common than subaxial injury. Serious sports injury involving the rec have a high rate of spinal cord involvement, and this is something we see in our adolescent population primarily. Spinal cord injury without radiologic findings on X-ray or CT is rare overall, but may make up to half of cervical spinal cord injuries in children, are more common in less than 8-year-olds. The prognosis is better in older children, again, because it tends to affect the subaxial area. Not surprisingly, the extent of injury on MRI does correlate with the prognosis, and findings do include ligamentous damage, disc herniation, and splitting of the hypervascular growth zone from the vertebral end plate, which again, very unique to children. Complications are common in the inpatient population. The most common complications in the inpatients are listed here and include ARDS, shock, which is something we'd frequently see in the emergency department but can progress onto the PICU as well, quadriplegia, and bowel and bladder complications. Of note, there's a 5-fold increase in mortality for axial injuries, and comorbid conditions, particularly substantial head and torso injuries, are also predictive of poor outcome. Interestingly, children who have a spinal cord injury or a C-spine injury related to sports injuries tend to have a higher rate of surgical interventions. This is increasingly becoming a fusion type procedure, but also can have halo traction devices as well. So the differential diagnosis for neck pain or neurological symptoms in an injured or traumatized youth can be challenging, and distinguishing between radiographically apparently CSI, SAWORA, or a peripheral nerve injury like a brachial plexus injury can be challenging. One example would be a teen football player who was hit while playing by another player and has tingling or burning sensation in the hands or upper extremities. And this could be from a central cord contusion resultant from, say, neck hyperextension, or even from a direct blow to the supraclavicular fossa, leading to a brachial plexus injury. Decreased neck movements or torticollis in children is actually quite frequent, and we see it a lot as a chief complaint in the emergency room, both after trauma and after other conditions like infectious processes. And this can result from direct muscle injury, muscle spasm, and atlantoaxial rotatory displacement, which is a displacement of C1 on C2, which is actually relatively frequent in the pediatric population. You can see that in the CT here to the right, where the axis and C1, C2 are rotated on each other and fixed. And these children tend to get a cock-robin type deformity where they have their chin pointed away from the top of their head. This can also happen after an infectious process, and in that case it's called Grisel syndrome. Unlike major C-spine injuries, these tend to respond quite well to rest and NSAIDs, and so a relatively minor problem. The most important part for many of us when it comes to C-spine injuries in our trauma patients, especially the younger ones, are how to approach clinical clearance and how to determine which risk factors for CSI are important at what age. And this can be exceedingly challenging for the best of us. Because the risks inherent to spinal motion restriction and neck irradiation during the evaluation of children after blunt trauma, it's really important to minimize the amount of radiation and harm we cause to these children. I will discuss nexus and PCARN rules in more detail in the next few slides, but each of these rules do tend to perform better at a specific age. For instance, nexus tends to work best in children over 8 or adolescent or young adult population, whereas PCARN rules for C-spine would tend to apply to 2 to 8-year-olds. Of note, children under the age of 5 years tend to be cleared just with a good physical exam. These are exceedingly low injury rates for these children under 5 years, and kids who do have a C-spine injury under 5 years tend to die from their injuries because they have axial C-spine injuries. So if a child is alert, stable, and biting the collar, they are probably clearing themselves, and it's acceptable to take the collar off and give them a trial of range of motion and see how they do. So the first clinical decision tool that I do want to talk about is Nexus, and this is something that is widespread in all of our emergency departments and used frequently, and a lot of us are very familiar with it. Nexus was initially developed in 2000 by Hoffman and his team, primarily in adults. The initial derivation only included 4 patients that were less than 9 years old and no patients under 2. Subsequently, a number of groups and studies have looked at the application of Nexus criteria in children. And unfortunately, injuries tend to be missed in the younger age group, so the kids, again, under 8. So the take-home message here for Nexus is that it may be applied to children over 8, especially if that's what you're most comfortable with. But there's no real evidence in the literature currently to apply to children under 2. A very, very challenging group of kids. The PCARN group in the US, so Pediatric Emergency Care Applied Research Network, conducted a multi-center retrospective case control study of 540 children with CSI matched to non-injured children that underwent imaging. And this is one of our landmark studies that have really influenced the way that we approach these spine injuries in our school-aged children. The study identified 8 risk factors that were 98% sensitive for CSI after blunt trauma, and you can see them here. These 8 factors are frequently used to decide about ionizing imaging as well as x-rays. So altered mental status, focal neurodeficits, neck pain and torticollis, more so than midline tenderness, substantial torso injuries, predisposing conditions like we discussed earlier, axial loading to the head through diving, and high-risk MVCs. Of note, in 2015, Dr. Leonard and the PCARN group actually carried out a sub-study to investigate CSI risk factors in age subgroups within the PCARN study cohort. Unfortunately, in the younger age group, again, like Nexus, the sensitivity dropped. So although both Nexus and PCARN tools have been widely adopted in the ED, there's still a desire for a robust, prospectively validated tool that can be used in all age groups, which is really the dream and would make all of our lives considerably easier. In 2019, PCARN again published a prospective study, this time observational prospective study of children 0 to 17 evaluated for blunt trauma at 4 PCARN sites, hoping to validate some of the retrospectively derived PCARN risk factors we've seen in previous studies. They came up with 14 variables that were associated with CSI. And what's interesting here is a number of these variables are similar to the initial PCARN cohort back in 2011 and 2001, but includes a number of other mechanisms that are interesting. Again, clotheslining came up, and this may come up, as time progresses because we're seeing more and more children on ATVs. But the other part that's interesting is there are some markers of injury severity here, including signs of basilar skull fracture and children with respiratory failure that logically would have a higher rate of serious C-spine injuries. The PCARN group, again, in this study, looked at their PCARN model, the original one, as well as a de novo model that focused a little bit more on axial loading mechanisms and respiratory distress. And both of them had excellent negative predictive value for CSI in children, with over 99% in both models. So some take-home messages from this study, which I found very interesting, were that there are risk factors out there with good test accuracy. And I think it is feasible to one day have a more definitive, prospectively validated tool that we can all use to apply to various age groups. Another interesting point from this study is that self-reported neck pain and difficulty moving the neck was way more predictive of C-spine injury than midline tenderness or findings on exam. And that makes sense because children are very challenging to examine within the trauma bay. And another possibility is children who are in spinal motion restriction do tend to have quite a bit of posterior neck pain by the time they come to the emergency room, making that clinical assessment more challenging. There's a high association between C-spine injury and head injury, which is not altogether surprising, but can help guide us when we're making decisions about including CTs of the C-spine in our severely head-injured patient. Respiratory failure could reflect substantial head, chest, and spinal cord injury, like I mentioned earlier. Interestingly, in this group of patients, high-risk MVC was not associated with CSI, and it really caused me to question whether or not we should be doing x-rays even for children just based on mechanism of injury. And we're really trying to move away from that. The authors of this study did suggest that further prediction rules should be stratified according to mental status. And a number of groups, and I'll talk about this in a couple of slides, are starting to look at trying to do just that. So imaging modalities, and this is the big question. Obviously in adults, we tend to progress towards CT imaging of the C-spine way more quickly, but actually plain films of the C-spine are quite sensitive in the pediatric population. There's a wide variety of sensitivities reported in the literature, anywhere from 75 to 100%. Of note, the lateral view is the highest yield view, so this is the cross-table lateral. The AP is associated with a number of false positives. And the odontoid view, which can pick up dens fractures or burst fractures of C1, can be very challenging in younger children and is really not recommended under the age of 8. Now, what to do about our young children? So, like I've mentioned in previous slides, children under 2 years of age tend to get axial C-spine injuries. They do not cooperate for odontoid views, and they're exceedingly challenged to evaluate. And so there are a number of authors and experts who do suggest if you're going to image the head in a severely injured child, considering adding a CT of the occiput to C2 to better image the CT in young children, because these are the injuries that are missed on X-ray as well. Now, X-rays can screen for injury, but there's a good body of evidence in the literature that suggests that CTs are needed to clarify injuries and often pick up other injuries that were not initially seen on the X-ray. So X-ray for screening, CT to clarify injuries. Some X-ray pitfalls, and these relate to the specific anatomy of children that I discussed earlier, but X-rays can be challenging to interpret in pediatric patients. There are a lot of normal variants that are different and age-based. Again, children under 8 tend to have very specific looking C-spines on X-ray, whereas kids over 8 start to approximate adults a little bit better. Soft tissues can be distorted by a crying child. They can lose their cervical lordosis like we talked about. And their wedge appearance, which you can actually see in this x-ray here, the wedging anterior can look like an anterior wedge fracture, compression fracture, and the posterior laminar fusion lines can also look like fracture lines. And therefore, when in doubt, don't hesitate to discuss the findings with a radiologist experienced in pediatric trauma. We all do it even in the pediatric trauma hospitals. It's very difficult to become an expert in pediatric C-spine x-rays. One thing that I do need to mention here is inflicted trauma. And what we're realizing more and more with time, that children who have abusive head trauma tend to have high rates of underlying C-spine injury associated with their injuries. And this was something we didn't recognize for a long time. Two recent publications highlight the importance of including evaluation of the spine in the assessment of children with suspected inflicted trauma. And here in the first study by Rabbit and her team, you can see children under 5 that were evaluated for abusive head trauma with an MRI of both the head and neck. 60% of their patients had a spine injury, and CSI was really associated with a more severe injury pattern. Furthermore, spinal subdural hemorrhages were associated with retinal hemorrhages, non-contact head injuries, and the diagnosis of abusive head trauma. In the second study here, they're looking at smaller children under 36 months with inflicted trauma, and the C-spine injury rate here was 15%. The injury patterns included retinal hemorrhages, shaking, lower GCS, and brain injury. And the authors concluded that the evaluation of shaken infants should always include C-spine imaging. And this is what we're starting to do at BC Children's Hospital as well. I'm going to touch briefly on blunt cerebral vascular injury, but this is a very challenging area in pediatrics, with a paucity of literature supporting what best to do, who to image, and what the real rate of underlying BCVI, or blunt cerebral vascular injury, is. We know that less than 1% of pediatric patients have blunt cerebral vascular injury, so likely less than the adult population. The number of different clinical prediction models, which many of you are aware of, that have been studied in the pediatric populations with variable results. And this includes the Denver, the East criteria, Utah, and most recently the McGovern score for motor vehicle collisions. The table here was taken from a really interesting study from a PEDS Trauma Quality Improvement Program study. And what they found here was a high association with skull-base fractures. And this study is actually at BC Children's, caused us to move towards doing arch-to-cow vascular imaging in all children with suspected basal skull fractures. And we'll track forward whether or not we're picking up a higher rate of blunt cerebral vascular injury. Interestingly, in this particular quality improvement program database, they only had a 0.2% rate of blunt cerebral vascular injury, so exceedingly rare. So given the complexity around C-spine evaluation, the multitude of different clinical decision roles that are out there, there really is this need for us to have a consensus guideline as to how to approach these patients. We know there's an incredible amount of practice variation across Canada, across the US, and even within the province with regards to our interpretation of films and our approach to their evaluation and management. And the most commonly quoted clinical practice guideline would probably be the TAC Pediatric Subcommittee guideline that was published in 2011. And their algorithm was based primarily on age and whether or not they could obtain a reliable exam. More recently, in 2019, a multidisciplinary pediatric cervical spine clearance group made up of orthopedic surgeons, emergency department physicians, and allied health made an updated clinical practice guideline. And this is the guideline that we've recently adopted at BC Children's Hospital for the initial evaluation and inpatient management. So there's a lot going on here, but I do want to walk through this pathway because there's some very interesting parts about it, which I do find is a really logical way of approaching cervical spine injury management and evaluation. So the pathway is divided by GCS, as previously recommended by the PCURN group in their 2019 paper. And so you have a GCS 14 to 15 group, a GCS 9 to 13, and a GCS less than 8, and they are evaluated differently. The committee consolidated the PCURN decision rules and suggested a simplified list of risk factors, which you can see here on the left. Note that substantial other injury is defined as an observable injury that is life-threatening, warrants surgical intervention, or warrants inpatient observation. Furthermore, the mechanism of injury on its own is not enough to get imaging, but high-risk mechanisms of injury may lower a clinician's threshold for obtaining imaging. The pathway here is primarily geared towards people working at high-level trauma centers, both in the community as well as a pediatric-specific center. And so if we just walk through it, the GCS 14 to 15 group goes to these risk factors, and you have the option of clearing the C-spine, which seems logical, as well as doing a plain radiograph, and includes reasons to call the spine consult service if they're available at your center, but also gives a number of options for further investigations or monitoring over the next couple of weeks, including maintaining the child in a collar and reevaluating in 2 weeks. Now, where this pathway gets interesting is in the lower GCS groups, and this is where there's a lot of practice variation. And so in the GCS 9 to 13, they give the opportunity for the child to improve over the next 12 hours and try to minimize radiation by foregoing a CT right off the bat and instead doing a plain radiograph with a CT if it's abnormal, or if they can't reassess the patient properly in the next 12 hours. And then you have the opportunity as well to clear the C-spine there. For the GCS less than 8 group, with a reasonable suspicion for cervical spine injury, they recommend going straight to CT. And this is something that's logical. You know, these are patients that have often severe head injury, torso injuries, and will often undergo advanced imaging of those other body systems, and hence there's not a lot to gain by delaying CT imaging in those patients. They also speak to the need for magnetic MRI within 48 hours in those patients who remain obtunded. And this is something that was a bit challenging at BC Children's Hospital previously on some of our inpatient services in terms of timing of getting an MRI to look for those ligamentous injuries or their spinal cord injuries that may have been missed on the initial trauma assessment. Does anyone have any questions about the pathway or anything up to date so far? No?
Hey, Jen, it's Meg Gilly. I just had a quick question for that middle GCS 9 to 13. In a lot of those traumatic mechanisms, we would be CTing the head of that patient in that group. Based on what you've mentioned before, would you recommend then extending that to C2 and then just getting lateral, like your radiographs for the remainder of your C-spines in that particular scenario?
So that's what I've traditionally been doing. You do have to remember, though, that, you know, one of the protocols we have for CT head imaging explicitly tries to avoid radiating the orbits and the thyroid. And the minute you get down past that occiput, you are radiating the thyroid. So being judicious is important. If you can reevaluate them soon thereafter, you could forego it, but I do think it's reasonable to add an occiput to C2, and I feel that most of our radiology colleagues have been pretty open to doing that as well. Any other thoughts from the group? So I want to come all the way back to the beginning of the management of patients with C-spine injuries to the pre-hospital setting and discuss spinal motion restriction. So I want you for a minute to think about this specific patient. This is a 3-year-old girl who fell from the 4th floor window. She arrives from scene by EMS, and they have some questions regarding whether or not they should forcibly restrain her versus using some of our clinical decision rules that we have in place. She's crying, reaching for her mother, very, very, very scared of everybody in the room, and practically climbing off the bed. She has no C-spine collar in place or rigid immobilization, and I just wanted to gather your thoughts on your approach to a patient like this.
So I personally would not immobilize her if she's crawling off the bed, spontaneously moving her head, and reaching for her mom, as described.
Anyone else have any concerns about this patient? Or would have a different approach to Dr. Gilly? No, everyone's with Dr. Gilly. There you go. And I would tend to agree, and this is something I struggled with for a long time, and I think our colleagues in the pre-hospital setting have as well. And in 2018, BCCH published a guideline with regard to spinal motion restriction for both adults and pediatrics, and you're likely familiar with the adult part of that guideline. But we do know that there are risks associated with rigid splinting, including airway compromise, aspiration risk, and patient resistance. And children, especially young children, can do a great deal of harm when forcibly restrained. It's amazing how hard they can fight you. And one other thing that we've seen in the literature is that these children who come in with C-spine immobilization in place or spinal motion restriction tend to get more investigations and spend a longer time in the emergency room and potentially even inpatient. And so there's a reasonable reason to try to avoid this when possible. So the BCCH guidelines currently have adopted essentially the initial PCARN rules. And so only patients with a low GCS who are not alert with altered mental status and a concerning mechanism, neurodeficit, complaints of neck pain, again from the PCARN rules, torticollis, multi-trauma, or predisposing medical conditions will have spinal motion restriction. And there's a bit of a caveat around the predisposing medical conditions, you know, within reason. If the child is still crying, fighting, sitting up on the bed and has trisomy 21, that child should not be forcibly restrained either, but just having a higher index of suspicion in those children when there are concerns.
Jen, there's just a question in the chat. It was regarding the C-spine clearance algorithm. The question is, what does potential to improve to GCS 14 or 15 mean in the GCS 9 to 13 group? Do we infer that they are going to get better, or do we watch them for 12 hours?
So, yeah, no, that's an excellent question. So we do have a substantial number of patients that will come in, say, who had a post-impact seizure in the pediatric population, or are very agitated and difficult to assess from a GCS standpoint. And those patients, you may initially, give them a GCS of 13 because they're not cooperative, or they've gotten medications on transport or gravel even, and are a bit obtunded. And those patients may potentially improve within even a couple of hours in the emergency department. But yes, this pathway does give up to 12 hours for those patients to improve. And so you could consider watching and waiting for 12 hours after plain radiograph. The child is obtunded where you suspect a high-risk mechanism or a head injury that's more severe, should just go on to have a CT directly as well. And lastly, on spinal motion restriction, and this is something I think we still can improve on, clamshells are really for transport times of less than 30 minutes. And this is a benchmark that I don't think we're quite meeting yet, but we're working on improving. And I'm open to any questions you might have. And I'm happy to go back to any of the slides previously as well. Anything coming up from your end, Mel?
So in the chat it says, thanks for the great talk. Any advice for non-BCCH sites, especially rural? Generation and interpretation of advanced imaging can be very challenging in this group.
And it is, and I mean, I think it's challenging for everybody. I do think, and I'm going to go back to this slide here, if you don't have access to a radiologist, getting to know some variables or variants in the pediatric population and an approach to C-spine interpretation can be really useful. There's a couple of fun little lines like the swish up line that you can learn that are relatively easy and you can look up in Google. But I would never hesitate to call down to a center that has a radiologist experience in pediatric C-spine interpretation And, you know, we do have a 24/7 radiology service that can provide that. And if not, you know, a trauma team later on that can take a look at the x-rays and run them by some of their colleagues as well in a high resource setting. But it can be exceedingly challenging. And I must say, for the most part, in suspicious trauma mechanisms, I'll run all my C-spine x-rays past the radiologist for the most part before I take off the collar.
Yeah, thanks, Dr. Ernst. I'm used to work in Golden, which is, for those of you who don't know, is in eastern British Columbia, and you'd have a kid go off a mountain bike or go hard on the boards, and it was often a mandatory trip to Calgary, immobilized, or very immobilized, which means your ambulance is gone for the day for a rural area, and most times nothing serious would be wrong, but I mean, now you're looking at particularly long transport times just to even obtain imaging. So, you know, I wonder if there's maybe a bit more of a role for observation. I mean, the trouble is with PCARN is that everything's done at a remarkably sophisticated site, you know, which has advanced the access to absolutely everything. And, you know, if you're 10 minutes away like I am at St. Paul's from BC Children's, is not one thing, but if you're looking at multi-hour transports, it becomes quite a different matter, especially when the family has to come along with them. So it just does become a little more challenging. It almost looks like the difference between rural and urban care has diverged even more in the last, you know, 5 to 10 years, just because of the greater emphasis on advanced imaging.
Yeah, no, for sure, and that's definitely a challenge. What I think I'm seeing anecdotally on a lot of our calls is with these sort of nexus and PCARN roles, people are feeling more empowered in the low-risk patients to clear them, but that does leave the higher-risk patients that do have findings. Now, the algorithm presented by the orthopedic group does allow for some observation, and I wonder if there's a role there for places like Golden, where you could potentially do your lateral x-rays of the neck, push them onto the grid and have them interpreted, and then watch and see how they do. And it's funny, a lot of the pediatric patients that we see in our emergency room, especially with mechanisms like cyclists, are especially downhill cyclists, we do tend to give them some Advil, Tylenol, take them off a hard board, and watch them for 4 to 6 hours. And a large proportion of these kids do end up improving and stop having that pain in the back of their neck. The other thing that I think has really helped us clear some of these patients clinically is not relying as much on that midline C-spine tenderness, which so many patients have once they arrive to the hospital, and really looking at that range of motion and the reported more subjective findings of neck pain. And I find that's been really helpful to clear some of the children that I historically couldn't clear because they always had that sort of C4-5 midline C-spine tenderness with no step off, no neurologic symptoms. They can move their neck fully, and I'm almost sitting there restraining them, which didn't seem like the right thing to do. So that's something else that can help. Thank you for your question. Anything else coming up from the group, Mel?
No, not seeing anything else in the chat. Any Jen can't see the chat, so if anyone wants to ask a question, probably it's easier just to
speak up
at this point.
Mm-hmm.
If not, I think that is it then. Thanks, Jen, so much for a great talk, and it is definitely something we all struggle with at all centers, including ours, so I really appreciate your time to talk about this today.
Thanks, everyone, for attending.
We've got a great lineup of talks for the rest of the academic half day, which will start again at 10, so we'll let everyone get a break and go from there. Thanks so much.
Hi, Melissa. It's Janet.
Yep.
I just wanted to make sure we're okay to pass on the host.
Yes.
Okay.
And for that with Joseph. Joseph, if you could just request the host, and I can give you the password. Just let me know when you're ready for the password, or I can type it to you. You're on mute. Can't hear you. I can see you talking.
Now let's try. Sorry, just need to know where the request button is on the laptop version of Zoom.
I think for me, Jen, it was on the bottom, wasn't it? Somewhere under more.
Oh, hang on. The way I've done things before is if I click on participants, hang on a second.
Oh, you know what? I can actually hear Joseph.
Yeah.
There. Are you the host now? Yes.
Am I?
Gave it to you.
Ah, okay, got it. Security.
Okay, thank you so much.
Okay.
Thanks.
I will say goodbye and go log into another session. Thank you.
Joseph, does that work for you?
Yeah, I think so. I'm just trying to make sure I've got everything here for ability to share screen and mute.
I can stay on for a few minutes just to make sure everybody, like for the first few minutes, and then I'll have to.
Okay, got it. Yeah.
Okay.
I think also there is also a technician online with us. I'm scroll through here and see if I can find his name. He was with us at the beginning, and he might have logged out, but he keeps checking back in.
I can send the information to Joseph from him.
Great.
He texted me the info. Ooh, see.
Oh my God.
That's not it. Sorry. I'll send you the option.
Yeah, I'm not seeing him on here right now, but he's kind of fading in and out. I know they roam around and they go from meeting to meeting.
Okay. I will get us started back at 10 sharp. I'm going to let people take a coffee break, a potty break, and anything else.
Thanks, everybody.
Thank you.
Okay. We'll start sharply back at 10, folks. we're just going to give it another minute and let people get back on.
Yeah, sorry, just trying to figure out again how to do my portion of screen because it's being tricky for me today.
You have permission to do it.
Thank you.
It should be allowed. I'm just going to get some rates and reviews for folks.
There we go. Okay.
Right.
Good morning, Megan.
Is that looking okay on everyone else's end?
Yep.
Awesome.
Good morning. It's Diana Chang here, Megan.
Hi.
Hi. How did you just start sharing screen? Like, how did you get that?
Yeah, so I went to share screen, and then I went under advanced instead of basic, and I chose share portion of screen. So then I can go into my PowerPoint and select presenter view, so I can still see my notes and my upcoming slides. And then there's a little green box that shows up, and I just put it around the current slide.
So for the next speaker, I don't know if Badri's on yet, but he would click on share screen on his screen.
Yep. Yeah, you didn't have to make me co-host or anything. It was just an option that I was able to click on.
So all the speakers can do that. They can just, once it's their turn, they just click on the share screen button on the bottom.
Yeah.
Everybody's enabled to do that for now.
Oh, perfect. Okay, so we don't have to keep making different people hosts.
Nope.
Okay, so I guess we have about a minute for until 10 o'clock and wait for people to log on here.
Meg, it's Badri here. Do you mind going over again how to share screen with presenter view?
Yeah, so at the bottom of your Zoom window, you'll be disconnected. You'll see share screen.
Yeah.
Then